Hello, I'm Dr. Kalio, 3 North attending. It's a pleasure to introduce Dr. Bonomo for Grand Rounds today. Just a little background on Dr. Bonomo. He graduated summa cum laude from University of Kentucky in 2012 with a double major in philosophy and psychology. He attended U of L medical school upon graduation. Um, he'll be graduating here in a couple months, and after residency, he will be picking up a position as medical director for the behavioral health and detox services at Mary Elizabeth Hospital. He'll be overseeing their 30-bed unit and detox unit. Dr. Bonomo's interests lie in neuromodulation. He's been trained here to do TMS, ECT, and ketamine. He hopes to expand the neuromodulation services for the south side of Louisville, and with special emphasis on treating patients with catatonia, nociplastic pain, and release phenomena, which is the topic of this grand rounds today.
Thank you, Dr. Clow. Well, it is a pleasure to be here today to speak with you all. I hope you all find this talk as exciting as it has been for me putting it together. Before we get started, I wanted to know you all to know I have no disclosures to report. Some learning objectives for today. We are going to try and characterize the relationship between sensory impairment and psychiatric illness. We're going to summarize the evolution of the perceptual release paradigm throughout history. And we are going to understand how to use release feature screening to guide management of patients experiencing perceptual disturbances. Let's talk about this. We live in an era of unrivaled technological access, one that would befuddle the imaginations of people even a mere half century ago. And science has given us access to a lifestyle that is truly phenomenal, but it comes at a cost. This intertwinement with technology places an ever-increasing demand on our senses, and that can have a profound effect on individuals and the mental health of our population. Sensory loss is a major cause of morbidity and mortality worldwide. The WHO estimates that upwards of 30% of individuals experience some form of moderate to severe vision or hearing loss across the world, and every expectation is that this number will continue to rise over the next couple of decades. But it's important to note that 30%, while a respectable amount, may not reflect what we actually see in clinical practice. Certain populations, particularly psychiatric populations, may be more vulnerable to sensory loss compared to the general population. And so we're going to talk about some specific populations real quick to kind of give you a way to kind of think about this matter. So take bipolar disorder. Bipolar disorder affects an estimated 2.5% of the population, but individuals with bipolar disorder are at a substantially increased risk for sensory neural hearing loss. This is thought to be multifactorial. It's related to lifestyle changes, increased goal-related activity, increased metabolic disease, and several epigenetic studies that suggest an increased risk for neuroinflammation. When you're thinking about hearing loss, there are multiple different types, but sensory neural hearing loss is the most common cause. When you lose your sense of hearing over time from age, we call that presbycusis, that's sensory neural. And when you lose it from noise-induced hearing loss, that's also sensory neural. But bipolar disorder patients are also at an increased risk for vision loss, and this is due to a number of largely metabolic-related issues. Increased risk of retinal detachment, retinopathy of prematurity, diabetic retinopathy, strokes, etc. Another population that's particularly relevant for is people that have schizophrenia. So interestingly enough, individuals with schizophrenia are at a reduced risk for developing hearing loss throughout their lifetime. But this is with the caveat that when you do a cross-sectional analysis of the population, patients with schizophrenia are 4 times more likely to have hearing loss relative to general individuals. So how do we make sense of this? Well, if you remember, one of the old theories on schizophrenia is what was called the 2-hit hypothesis. The idea was that there was a genetic predisposition and then some kind of environmental trigger, oftentimes an infection in the neonatal or early years of life, can cause someone to become syndromic. And many of the infections that are associated with schizophrenia, such as CMV, rubella, HIV, HSV, as well as toxoplasmosis, all have a profound increased risk for congenital or acquired sensory neural hearing loss early in life. In addition, several of those infections, CMV, rubella, and toxoplasmosis, also increase your risk for congenital vision loss. And patients with schizophrenia are actually at a substantially increased risk for visual dysfunction. But it's important to note that not all visual deficits can be equated with vision loss. When I'm talking about vision loss in the context of this research, I'm talking about something called bottom-up processing deficits. So if you all remember back in medical school, you all learned this kind of visual pathway. Light enters from the visual field into the eye. It stimulates the retina tissue, transfers it through neural tissue into the optic pathway. It goes through the chiasm, decussates, goes to the thalamus, ends up in the visual cortex. And this is one aspect of the perceptual circuit for vision, but this is only one part of it, and it's actually quite a simple part of it in the grand scheme of things, because there's a whole amount of post-perception processing that undergoes. So this is an image taken from a study on schizophrenia, and I would actually say this is still quite simplified as it leaves out the entire aspect of the salience network and lots of frontal circuitry. But essentially the gist of it, information comes in through the eye, gets transferred to the visual cortex. That's the bottom-up processing factor. And then after that, it has post-perception processing through the dorsal and ventral stream to the frontal lobe. It's interpreted by the salience network, feeds into the limbic system, and the temporal lobe comes back, and it synthesizes it, sends it back to the perceptual circuitry in the visual cortex. So we'll talk about this more later, but this is the general way of thinking about this. So when we're looking at vision loss, we're talking about bottom-up perceptual circuit dysfunction. So let's kind of look at how you approach a population like schizophrenia and determine if they have an increased risk of vision loss and try and understand why. So these are the different aspects of why people with schizophrenia are thought to have issues with visual dysfunction. So there's some post-perception processing issues in the dorsal stream, they have poor optometry follow-up, increased metabolic disease, higher rates of medication side effects, abnormalities in retinal structure and electrophysiology. Now, not all of these necessarily contribute to vision loss. For example, obviously changes in the dorsal stream, that's a post-perception processing, that's a top-down processing issue. And that's one of the key features of schizophrenia is that dysfunction in the dorsal stream, but that's not what we're talking about here. But many of the other issues are relevant. So if you don't follow up for optometry care, you're more likely to have myopia, have it progress rapidly, you're more likely to miss a visual issue that you can have corrected. They have increased risk of metabolic syndrome, very similar to bipolar disorder. Numerous medication side effects factor into the risk for having vision loss, particularly angle closure glaucoma from anticholinergics. And then there's a whole wide range of antipsychotic adverse reactions that are relatively rare. They also have abnormalities in retinal structure, which we already talked a little bit about with the congenital infections. But one thing that deserves a little bit of attention is this retinal electrophysiology. Well, this is something that I myself wasn't very familiar with until recently, but individuals with schizophrenia are actually believed to have hypercolor vision. That's to say that when they perceive colors, it's supposed to be more intense relative to the general population. So dopamine modulates the firing rate in retinal tissue, and during active psychotic episodes, individuals with schizophrenia send excess dopamine to the retina. It actually increases the activity of the retinal ganglion cells by keeping them active and polarized, and as a consequence of that, they can get optic nerve inflammation and vision loss. There also is some old research that suggests patients that have schizophrenia that's untreated for a long time actually lose their sense of vision as they get older. And that's something that may be relevant to think about when you're looking at the trajectory of their life course. And then the last population we're just going to briefly talk about is dementia, which is one that's particularly relevant when you're talking about sensory loss. So there's a recent study, this actually came out this year, that showed that the lifetime risk for developing dementia is far greater than we expected. And they estimate almost 50% of the population will develop dementia after the age of 55. And this is thought to double by the year 2060. And it's a very relevant issue for our field. Patients with Alzheimer's, Parkinson's disease, and dementia with Lewy bodies all have higher incidences of vision and hearing loss relative to age-matched controls in the population. And there's a lot of different theories on why this occurs. The general perspective that some people have is that there's a shared pathophysiology. Some kind of inflammation causes both issues, in that sense, somewhat incidental. But there's an alternative line of thought, which is that the sensory impairment itself actually contributes to the risk for dementia. And this is supported by evidence that optimizing vision and hearing actually will reduce your risk for having dementia. And it's a good primary intervention for the population. So what's the big picture here? Individuals that have psychiatric illness are more likely to struggle with sensory impairment relative to the general population. And this matters because sensory loss can complicate the management of psychiatric illness. There's a growing body of evidence that suggests that sensory loss can increase your risk for developing various forms of mental illness. And so some of the notable ones that have been observed from cohort research is major depressive disorder, bipolar mood episodes, general anxiety disorder, PTSD, schizophrenia, virtually every form of dementia, delirium, and hallucinations. Now, I want you all to take a second to think about this list. And I want you to imagine someone you know or yourself developing hearing loss, developing vision loss, and ask yourself, do you think that would cause you to actually develop any of these illnesses or take a subclinical illness to make it syndromic? There's a lot of different ways you can look at this. We're going to return to this later, but I actually think that there's a lot more here than most of us probably realize. But the main topic for today is over hallucinations, and so that's where we're going to go next. So we're going to cover a brief history of sensory loss and perceptual disturbances. This is 300 years worth of research, so we're going to just touch the key highlights so that we can get to the meat of the stuff that we've revealed the last couple of months with the research we've done here. So in 1760, the Swiss naturalistic philosopher Charles Bonnet first described the relationship between sensory loss and hallucinations. Essentially, his elderly grandfather, when he was in his 80s, had cataract surgery. He had no problem with any medical illness prior to that. After he had cataract surgery, his vision got better, but it rapidly deteriorated. It's very common. A lot of people get post-retinal scarring from cataract surgery. They lose their vision again. And when he lost vision for the second time, he started to have hallucinations. Charles Owen was a respected member of the community. He was a magistrate on the Grand Council of Geneva. There's no suspicion that he had any form of psychiatric illness, and so these hallucinations were puzzling. And Llewellyn described these hallucinations in a particular way. They were vivid, very clear. They were the most real thing that he saw on a day-to-day basis. A lot of times it was people that he kind of felt like he knew in his life, maybe like a girl or granddaughter, but it wasn't anyone he could particularly point out. They were complex. That means they were a fully formed image, and they were often distorted in size. And historically, we emphasized that they were Lilliputian, that they were small, but there were several cases of described being Brobnagesian, which means that they're bigger. And both of those terms come from Gulliver's Travels, which was wrote in 1726 by Jonathan Swift. The hallucinations were also externalized. They were in the environment around him, but he retained insight. He said, I know these shouldn't be here, but it's still kind of strange that they're there. And so if you want kind of a example of what this looks like, it's something like this, where you have some kind of object, it's portrayed in your vision. Oftentimes it presents in a stereotypical manner, meaning you see it over and over again. It leaves an after image. There's some form of perseveration, and they just don't look like they're supposed to be there. They're just not the right size. Now, the caveat here is that most people that have Charles Bonnet syndrome, they have visual impairment, so they actually have pretty bad vision. So these things would be even more profound. It'd be if you have glasses or contacts, imagine taking out your contacts and you're walking around and you see this, but you can't tell anything else. So that difference, it's pretty easy to point out. And it's not surprising that someone like Charles Owen, who was relatively with it even for his old age, could tell that this wasn't supposed to be here. Now, Bonnet was a naturalist. He was a scientist in his own way. And he saw this as sort of a dysfunction of the natural way that consciousness worked. He felt like consciousness would flow into the environment, take in information, and come back. And he just thought that the sensory loss disrupted that balance, similar to like the tides being disturbed. Interestingly enough, this actually got lost from history for a long time, but Bonnet himself developed vision loss in his 20s. He was totally blind by 40, and he lived for 33 years with visual hallucinations almost his entire life. But it took over 200 years until Charles Bonnet syndrome was formally named. It was done by a Swiss neurologist by the name of Jorge de Morzier. He actually started talking about Charles Bonnet in 1935. He presented a case at the International College of London on an individual who had a Charles Bonnet-like syndrome. He had complex hallucinations, but he did not have any visual deficits. His vision was otherwise intact. And de Morsier would later go on and call this Charles Bonnet syndrome. He would publish his formal treatise in 1967. But he had a very controversial perspective on the illness. He thought the vision loss was completely incidental. He said this is a localized form of neurodegeneration. It's not a dementia, and that it's a coincidence that patients have it because you just happen to lose your vision when you get older. So this generated a lot of controversy. Almost all the ophthalmological community, many psychoanalysts disagreed with him, but he still brought up a good point. Someone had a CBS-like syndrome without any vision loss. And how do you explain that? So the debate raged on for about half a century in France. Eventually, the British started spreading the concept of CBS to the world. And eventually, by 1989, two American psychiatrists, Kenneth Gold and Peter Robbins, started to change the way we think about CBS. They wanted to focus on phenomenology, not on etiology. They said, we don't know what causes CBS, but we know it's a very unique phenomena. So let's focus on the phenomena. Let's create some criteria for that so we can investigate all of the etiologies. And these are the criteria that they came up with. And these are the most commonly accepted criteria for Charles Bonnet syndrome. So they said that the hallucinations have to be visual, particularly visual. They have to be formed, complex, they're persistent, repetitive, stereotypical. Those are all really very similar concepts. And then the patients have to have insight that they're real, or they have to regain insight that they're not real. They can't be delusional in any sense, and they can't have any other hallucinations. Now, this became the gold standard for CBS for really the last 30 years, but the paradigm was never universally accepted. And it's interesting because despite the intersection this has with psychiatric illness, CBS obviously doesn't exist in the DSM. Ophthalmologists, neurologists, psychiatrists, we all deal with patients that have these kind of syndromes, but no one really specializes in it. No one pays it that much mind. And we're going to talk more about that in a minute, but there's 3 specific flaws that we have to talk about with CBS, because the paradigm itself is part of the reason why this never took root. And those 3 flaws regard its core phenomenology, the restrictiveness of its exclusion criteria, and an inability for the CBS paradigm to explain the paroxysmal nature of the phenomena. So to try and organize some of these thoughts, I'm going to lean on one of my favorite physicians. He died a few years ago, but he was a neurologist by the name of Oliver Sacks. Sacks was a vocal proponent of normalization of perceptual disturbances. He thought they were extremely common. He thought they were overlooked by virtually all physicians. And he really dedicated much of his later life to trying to normalize and destigmatize these disturbances. So Sacks said that there is clearly a wide array, a whole spectrum of visual disturbances which can occur when vision is lost or compromised. He's one of many physicians that disagreed with restricting CBS to complex phenomena. He suggested that simple disturbances may occur as well. So simple hallucinations are not something we talk about very often, but simple hallucinations are unformed or elementary. Epilepsy studies suggest they originate in the sensory cortex compared to complex phenomena which originate largely in the temporal lobes. And Sacks suggested that the simple visual hallucinations that many people experience when they lose their sense of vision is a form of CBS, and is actually a prodrome that comes on prior to people developing complex phenomena. So to put this in perspective, these are some examples of simple perceptual disturbances. So almost all simple disturbances from the visual domain can be referred to as photopsias. It's some light phenomena. And so here on the left, you have someone that has different rays of color. You have kind of like a blurring, a general aura in the middle. On the right, that is something that's very particular, very good to know about. It's what's called a fortification. That's a specific type of photopsia that's common in migraines. And you actually, if you ask patients that have migraines about aura, that's most often what they see. You show them a picture of that, they actually will almost always tell you, yeah, that's what I see if it's actually a migraine aura. But there's another set of unique kind of photopsias called phosphines. So if you're ever rubbing your eyes or you kind of have like a sigh and you're trying to do a warm compress, you'll notice you'll get some visual disturbances that you see with your eyes closed. If you stare at the sun and you get that after image, that's also a phosphine. These are technically photopsias, but they're a little bit different because they're more closed-eyed and they're not usually as, I guess, elaborate. But these are some forms of simple perceptual disturbances. And Sacks did a lot more than just talk about this. He also mentioned that complex visual hallucinations and CBS are not simply memories. So Sacks said that it was all of his clinical experience. When he talked to patients that had CBS, they very rarely knew what it was that they saw. They could say it's a dog, but they couldn't place it from anywhere in their life. And he said this is a very notable difference from dreaming, where individuals usually have some familiarity with what they see. Now, Sacks and others commented that they felt like this was a proto-object, a proto-image, kind of like an abstract form that somehow our psyche has, and we use it to instantiate in our visual field. And so, for example, if a patient that has Charles-Bonnet syndrome sees a cat, it's not that they see their cat, it's not some cat they saw in their life, but the argument that Sacks makes is that it's actually just some general form of a cat. Now, I'm going to take a disagreement with this, but we will get to that in a little bit. But there is a key point here, which is that there's a lack of familiarity with what people see when they have these kinds of disturbances. Sacks also mentioned that hearing loss is a very common alternative form of sensory loss that he thought was related to CBS-like phenomena. He talked about musical hallucinosis being very common in individuals that lose their hearing. He drew the analogy himself in several of his works. Nowadays, many people refer to musical hallucinosis as Oliver Sacks syndrome or auditory Charles-Bonnet syndrome. And a 2018 study actually confirmed Sacks' suspicion that hearing loss is the most predictive factor for later developing musical hallucinosis. But there's a whole other matter here that we have to talk about. So beyond the disagreement over what is the phenomena underlying CBS, we have to ask ourselves, why are there all these restrictions? Why did delusions disqualify you? Why can you not have other forms of hallucinations? And Sacks didn't directly take aim at this, but it's interesting because from his own work on Charles-Bonnet syndrome, he highlights the issue here. So he talks about how one of the defining characteristics of Charles Bonnet hallucinations is the preservation of insight. The realization that the hallucination is not real, people may be deceived temporarily, they usually restore insight. But he then goes on to immediately say, but if they have dementia, they may have less and less ability to recognize hallucinations and they may become delusional and psychotic. So in clinical practice, it is quite possible for you to see individuals have Charles Bonnet-like syndromes that don't qualify because of these exclusion criteria. And you have to ask yourself, is that really fair? Does that even make any sense? You could be diagnosed with Charles Bonnet syndrome today, you develop Alzheimer's, and you no longer qualify. There's something fundamentally wrong with that approach. And this has been pretty well traced throughout many aspects of our field, many aspects of other fields as well. So there are different ways that people try to encompass neuropsychiatric populations for Charles Bonnet syndrome. Some people talk about Charles Bonnet syndrome plus or atypical CBS. And a systematic review that was done in 2019 showed that there are actually 33 different sets of diagnostic criteria for CBS. When you look at this disagreement, I have up here just from a study that we did, kind of summarizing these results. Essentially, there's no criteria that is universally accepted. Even when you look at something that's very commonly expected, which is this idea that you have to have complex hallucinations, only 3/4 of studies say you need to have some specification on hallucinations, and then 2/3 of them mandate complex. It ends up being a 50-50 split. Half the people that diagnose and treat CBS consider simple phenomenon, half of them don't. Almost all of these things are 50-50 split. That means that people are regarding completely different populations with having completely different phenomena as being the same illness. What does that really mean? Well, it means that we don't know exactly what we're doing. And this disagreement is partially because the history of CBS is tied in with a lack of understanding of how the brain works. So we know now that it is not simply ocular pathology that causes Charles Bonnet syndrome, but rather deafferentation, a reduction of incoming afferent sensory tone. So when you look back and you see the more serious case that he presented in 1935, that individual likely had a small stroke and part of the optic radiation. He had deafferentation. He didn't have any clear visual deficits, but he did have some kind of explaining illness. And so CBS really is talking about post-deafferentation hallucinations, and they're often qualified as occurring in otherwise normal individuals. But over time, in the shadow of this commentary, there's been a movement away from the Charles Bonnet syndrome paradigm. And some individuals have suggested, myself earlier on as well, that we should talk about this as a deafferentation or release hallucination. And there is some benefit to this because by shifting the paradigm to talk about the phenomenon, getting out of all these restrictions, you are able to talk about this in our population and of patients that we care for. And this may be relevant because release phenomenon may aid the treatment of psychosis. Generally speaking, individuals that have release phenomenon do not respond well to high potency antipsychotics. I have included here a study actually from Dr. Casey around chair. It's the first one I could find in the literature where they had an individual that had macular degeneration. Both of them did not respond to haloperidol at all. And that's something that we've seen over time, is that some antipsychotics don't work. Sometimes that's why the psychiatrists don't treat this because we say we don't have a role to play here, our meds don't work. But it's not really that simple because a lot of the low potency, a lot of the atypical agents do have a better response. And that's something we'll talk about here as well. But even with proper pharmacological management, sometimes you need a little bit more. And correcting the sensory impairment, what I call reafferentation, is truly the gold standard for managing release phenomena. In addition, we've got some clarity that's been added to the discussion as neuropsychiatrists and circuit psychiatrists have kind of talked about this issue. So there's one particular individual, Dominic Feach, who's at King's College of London, who spent almost 2 decades characterizing this work. What he has shown is that deafferentation appears to provoke hyperexcitability of the sensory cortex as well as the salience network. This is Professor Feach here giving a lecture on CBS in his office. This is kind of a way to summarize some of the findings from his research. So you take the normal visual pathway, look what happens when someone gets deafferentation. If you hit the retina, the visual field in the proper way, you end up damaging both sides of the pathway. You'll get changes in the thalamus, increased metabolism, increased blood flow. And then you will also see a change in the sensory cortex where you get increased excitability, but a reduction in blood flow and metabolism. Perhaps the more interesting part of what changes here, though, is regarding the salience network. So we're just now trying to get to the stage where we understand intrinsic neural circuitry. Intrinsic neural circuitry refers to pathways that we are kind of born with. They may have some interaction, some growth after we're here, but there's something inherent to being human. And two of the most interesting, most relevant intrinsic neural circuits is the salience network and the default mode network. And these two circuits kind of work in parallel or in opposition to one another. The way that you can think about it, if you want a very simple way to look at it, the salience network determines the state that you need to be in. Are we in a active problem solving, a task-oriented, the task-on mode? If that's the case, it suppresses the default mode and it tries to solve the problem. Directs attention, tries to kind of incorporate higher executive function. It does all this through the output of the frontal parietal or the central executive network. But there also is the default mode itself, which is our rest state. As Aaron Beck put it, this is the collection of schemas that we have in our life that sort information. It can be biased if we have our own illness, but it's something that's already there. And so when you get salience dysfunction, you get hyperexcitability that can manifest in a number of different ways. In general, it's going to shift you out of the default mode. You're going to be stuck in this task on trying to solve a problem that may make you ruminate, that may make you anxious, that may make you hypervigilant. When you're looking at acute psychosis, something that responds well to D2 antagonism, that is often thought to be a salience dysfunction. That is due to the salience network persistently maintaining salience, importance of something, keeping someone fixated on it. And so when you're looking at it like this, there's a whole different way to think about the visual hallucinations. And we'll get to that in a second. But one other thing that's interesting about the salience network is that it is part of what's called the incident fasciculus. So the incident fasciculus runs from the frontal lobe to the temporal lobe. It also runs through the insula, through the limbic system, and so it actually is a core feature of the salience network. And the incident fasciculus is one of the most interesting parts of the brain because it consists of a very unique set of neurons called von Economo neurons. For those of you who are not familiar, von Economo was the individual who discovered encephalitis lethargica. He also did a lot of histological research, and he found that humans and some great primates had very unique neurons that are very rapid, very long. So these are the quickest neurons probably in our entire brain, and we don't really know what this fasciculus does. It has been researched for almost 2 or 3 decades now, and we don't truly know what all we need it for. But we do know that it plays a role in mimetic memory. And mimetic memory comes from the same term as what it looks like. It's about memes. So part of our episodic memory includes mimetic memory. A meme is a very unique, salient, episodic event in your life. Think about graduating from college, whatever you think about the first vision there and all the feelings, all the emotions that are associated with it. So that's a meme. And when we are trying to determine salience, determine what's important, part of what that network does is it uses our mimetic memory to say, okay, what is the situation like? What have I been in? What kind of circumstances have I been in that are characteristic here? And that's how we kind of interpret. That's how we get affect-laden material. And I think this ties in very characteristically to a lot of the ways that we think about visual hallucinations. Because if you remember, Sachs mentioned that individuals with Charles-Bonnet syndrome are not familiar with what they experience. So we have to ask what's going on here. And so kind of to figure out and talk about what we were mentioning a minute ago, I'm going to lean on one of my favorite philosophers, Wittgenstein. So Wittgenstein did a lot of work on language, and he actually really argued against the idea that we have innate concepts. And what he said is that when you look at the world, you look at what's true, all that there is, the world is all that is the case. That's to say, all we have is our experiences. We have the things that we encounter, the things that we learn about, and we form these into organized structures. And so he uses the analogy of a tree. When you're thinking of something like a cat, it's not that there's an abstract form of a cat. We have all these different things that we refer to, that we call a cat. They all form a common basis. And when we're trying to recall that, it's kind of like a tree. You go down the trunk, you start asking, okay, is it big? Is it small? Does it have this color or that? And then eventually you get to the individual instantiation of what you have. But that actual concept, that cat, that's just an abstract entity. It's just a conglomerate of what you have. It's not really anything. And I think this is kind of what's going on when patients have complex hallucinations from release pathways. You get this hyperexcitability in the salience network, and you get a firing from the sensory cortex that goes through the salience network, and it starts asking our mimetic memory, what is this? And it goes down the pathway, it gets as close as it can, and then it overlays that in our visual field and says, is this it? Well, if there's a matchup, our brain will say, I am familiar with that. If there's not a matchup, you don't recognize it, even if you've seen it 100 times. And this is what happens with many delusional misidentification disorders, with Capgras delusion, with body dysmorphic disorder, is that we don't recognize it as being us, as being what it's supposed to be. And that's a different matter than actually having seen it. So I disagree with Sachs. I think that we actually do see, we have seen the things that we hallucinate, whenever we have Charles Bonnet episodes or release episodes. But I think that there's another mismatch, is the circuit dysfunction. Now, I want you to think back about what we were talking about earlier. I'm not asking anyone here to agree with the particular circuit-based model that I'm presenting. I want you to think about the concept, though. I want you to think about that exercise that we did. All of these different illnesses are associated with sensory loss. A correlation does not prove causation, but it does imply it. That's why we do correlational research. And I want you to think about all these illnesses. How many of you all thought about a circuit-based explanation for why people develop these illnesses? Because I'll tell you what, when I first started reading this research, I didn't think there was anything here. I figured these are incidental. It's psychosocial. You lose your sense of vision. You can't see the kids that you raise. You can't enjoy the things that you like. You get depressed, or maybe you get stressed out. You get anxious. Very psychosocial explanation. But we have to remember something here. We are not simple biologists. We are not psychologists. We're not sociologists. We are psychiatrists. We are physicians. We are tasked with understanding the physiology of the mind. And the physiology of the mind is electricity. If I were to have a family member that went to see a cardiologist, I would not be comfortable if they told me, I don't care about the AV nodal circuitry. That's not part of my job. I'm not going to learn that. I'd go see someone else. And in a decade or two, I think the same thing's going to happen to our field. We are going to be expected to understand circuitry. We're going to be expected to try and modulate treatment based on that. And that's what we are paid to do. We are physicians. So if we don't understand the circuitry of the mind, who will? But let's turn back to what we were talking about with the Charles Bonnet syndrome, with the release hallucination paradigms. They both share a characteristic flaw, one that's particularly relevant moving forward, which is how do we explain this paroxysmal nature? Well, lots of people lose their vision and hearing. Now, we talked at least 30% of the population, but not all those individuals experience release phenomena. Even in the most gratuitous studies, it's only 30% of patients. So that's what, maybe 5 to 10% of the population might have release phenomena. That's what the studies suggest. And even if they do have them, when they occur is very variable. There are certain things we've noted. They're usually at night. They're usually isolated. But they may happen for a year and go away. They may take 10 years to start. And the Charles Bonnet syndrome gives us nothing to explain that. And that's important because we need pathophysiology to buy into this. So there's a way to get around this. And I think this is the way that we have to move forward. Deafferentation has historically been seen as an isolated risk factor for hallucinations, but it should be seen as a larger part of an interconnected system of dysfunctions that contribute to perceptual disturbances. A hallucination that occurs due to multiple factors is what's termed a multimodal hallucination. And multimodal hallucinations likely better explain the nature of psychiatric illness than anything that we actually approach, than any specific diagnosis that we see. I mean, you think about someone that has bipolar disorder. Not all of them have hallucinations, even with schizophrenia. How do we explain that difference? And that's because there's multiple things at play. And then there's a beautiful study that was done in 2023. It was organized by a particular neuropsychiatrist who got all the leaders of every different visual hallucination research program together. They all put everything together to create a model. We're not going to go over the details of this because this is far beyond the scope of what we have time for. But I am going to show you the takeaway that they had, which is this little model here. So when you're looking at perception, we have to really think about what that is. What is it that we're experiencing? So when you have visual information hit the retina, there is a delay until your brain actually sees what you saw. It's about 80 milliseconds. And 80 milliseconds can make a difference when you're trying to decide whether or not you're going to run away, whether or not you're going to fight someone, what you're going to do. And beyond that, what we see, if we were not to use the complex circuitry of our perception, would be absolute chaos. We actually see 15 seconds worth of information. Our brain smooths the edges over, puts everything together to make what we see stable. So we can make predictions, so we can have expectations, so we can go and make decisions that will keep us alive. Well, there's a lot of ways that we have to do this, and there's a lot of ways things can go wrong. So think about it like this. We are creating an expectation, what we think we're going to see in each moment. Our brain compares this expectation in the visual cortex to what we are actively seeing. To do that, it needs to use a lot of aspects of attention, of frontal cortical demand, a lot of that salience. And so we use that to see if what we're expecting is what's there. What we see is altered by the eye, by the information that comes in, by our attention to that, by the arousal state that we have. And if there's a mismatch, then we have problems. And so when that data comparison doesn't line up, When you have a processing deficit at any part of this processing system, you get hallucinations. But deafferentation, though it is a part of the matter, it's not the only thing here. Attention can play a fundamental role whether or not someone with deafferentation actually hallucinates, as can their arousal, as can their mood states. And when you start looking at things from a multimodal perspective, you start to realize that it makes a little bit more sense. It also actually can tailor treatment paradigms. So if someone is hallucinating and they have predominantly inattention, there's an argument to give them a stimulant, give them something to actually increase their attention. If they have issues with arousal, you want to try and give them something to calm them down, kind of sedative. And integrated models better explain the phenomenology underlying release disturbances and hallucinations in general. But you come into a problem when you move into the multimodal hallucination paradigms. What is a release hallucination? How can you ever know that release is the only thing at play here? And in fact, if you look at the prior research, the fact that most patients with deafferentation do not experience hallucinations, to me, that suggests that probably all release phenomena are multimodal. And so then what is a release hallucination? What are we really talking about here? So does deafferentation really matter? Should the hallucination really be our emphasis, though? That's one of the things that I actually take issue with. Prior research has kind of argued back and forth. Oh, this is the type of hallucination that matters in deafferentation hallucinations. This is what CBS is like. Well, clearly that approach is not working. You know, we've had tons of disturbances, tons of disagreements over 300 years. We haven't gotten anywhere. And so I actually would like to suggest that the core phenomena is not what we see, it's not what we hear. It's actually the unseen process. It's the circuit dysfunction that causes all the other factors. And that's what I call perceptual release. So perceptual release is a phenomenon whereby deafferentation of bottom-up perceptual circuitry provokes hyperexcitability in a corresponding sensory cortex. This hyperexcitability allows for the capture or the release of previously subthreshold stimuli or may alter the morphological presentation of multimodal hallucinations. This perceptual circuit dysfunction may provoke downstream disturbances in other intrinsic neural circuits, such as the default mode or the salience network. When you move to a perceptual release paradigm, you're not bound to the visual pathway. So this is a model that I use to kind of explain in a very simple way how you get release from the auditory cortex. But the question is, how do we identify perceptual release if you can't see it? Well, the simple way to do it, which is actually not pragmatic, but definitely reliable, is to use fMRI. But is that really what we need to do? So I want you to think about this for a second. Imagine you're in the middle of the jungle. So one of your expedition members comes up and says, hey, I think this guy's having a stroke. What are you going to do? Are you going to say, I don't have an MRI machine, I don't have a CT scan, I guess he's going to die? No. We learn physical exam, we approach it, we ask him questions, we try and localize lesion, we try and decide what to do. And we don't need imaging to determine that someone has perceptual release. But what we do need is something like the National Institute of Health Stroke Scale. We need an efficient way to approach and diagnose and detect that someone has perceptual release. And that is done by looking at what I call release features. Release features are physical characteristics of an individual, vision loss, hearing loss, as well as the qualia of their perception, that's to say what they see, the subjective reality of their perception, that heralds the presence of perceptual release. And we actually have some help here because we spent 250 plus years trying to figure out what release features are. All the CBS disagreements, all the different paradigms people came across were all different possible candidates for release features. They're looking at different populations, trying to rule out the non-confounding variables, but that actually is very helpful because since they did not look for perceptual release in psychiatric populations, they're able to more characteristically identify what is intrinsic to the perceptual release phenomenon. So there's some things that we're going to talk about: complex visual stereotypies, prodromal simple visual hallucinations, enhanced clarity, retained insight, and nocturnal proclivity, so forth. But once you take all those release features, you have to remember, psychiatric populations have perceptual disturbances. Not everything's about release. And so it's important to look at release features, look at deafferentation in psychiatric populations. And so that's what we did. Working with Dr. Clall, Dr. Summers, several medical students, several residents, we ran a study for 4 months earlier this year that aimed at identifying release features. So we looked at patients at U of L. I screened every individual I could on 3 North on the consult service. We waited till they were stabilized, so they were not psychotic. And then we asked them, do you have any problems with your vision? Do you have any problems with your hearing? Have you ever had any perceptual disturbances? We ended up seeing almost 200 patients. We had a way to kind of roll out people that were malingering, that were just giving us pan-positive answers. And there were three things we were looking at. So there was a sensory exam, a hallucination survey, and then a decision on could they be having perceptual release. And so this is the comprehensive deafferentation exam. One of the key things that we did is we used the tuning fork. So everyone learns about the Weber and the Rhine test in school. They're actually pretty helpful. So using bilateral Rhine test and a Weber test, you get 97% sensitivity for detecting hearing loss. And it's 86% specific for the type. And it's a pretty simple test. It's actually very reliable, very reproducible. But there's one problem with the 3 tuning fork test, which is that it can't detect bilateral, low-grade sensory neural or conductive hearing loss. But you can a lot of times just by talking to the patient. When you're talking to someone, they reach over, they can't hear, they ask you to speak up, they seem very confused. Those are some cues that someone's having problems with hearing impairment. We also assess people's vision using a Snellen chart at a 10-foot fixed distance, an Amster grid to look for macular degeneration, and then a binocular static finger wiggle test, which is look for peripheral vision loss. So we did that on every patient after they were stabilized. We asked them for their hallucination history. And this is one of the things that if you take anything from this lecture, I'd like you to think about this. So I was very fascinated when we started this study, because when you approach a patient and you ask them about their physical, what they call their physical health, ask them if they have problems with their vision, ask them if they have problems with their hearing, you do some assessments, you educate them about that, and then you ask them, sometimes when people have sensory loss, they see things, hear things that aren't there. Doesn't mean they're psychotic, could be, but it's not essential. Does that ever happen to you? People participate much better. They'll tell you way more about hallucinations, and you'll realize that we actually are very bad at identifying hallucinations in most individuals. They don't talk to us about it. They don't want to be seen as crazy because we're not normalizing these phenomena. And by talking about sensory loss, it's very easy to normalize it, and you'll get much better research, much better interesting discussions with patients. So we looked at all these factors. We'll kind of go over what stuck out whenever we wait for the results. And then we tried to decide, could they be having perceptual release? What we're really looking for here, is there a confirmed vision loss? Is there a visual disturbance? Is there a confirmed hearing loss? Is there auditory hallucination? And we excluded certain things. So when they did historical research on Charles-Bonnet syndrome, there are certain visual acuities you have to qualify. So that's a visual acuity with binocular with both eyes of 20/60, or a unilateral vision loss of 20/100. And this is what we found. 70% of our patients at pre-North or on the consult service had some form of sensory loss. And this is rolling out most of the mild types. This is actually specifically talking about from looking at the thresholds that can cause release. This is 3 times higher than the rate of substance use. It is the most common problem that our patients have. And if you look at it, we had a pretty big split. So there's a lot of vision loss and a lot of hearing loss. So you really can't just consider one domain. And sometimes it's really not that hard to even think about. When we walk in the room, a patient has glasses on. Do you think, oh, they have vision loss that might cause them to hallucinate at night when they take their glasses off? It's really not that hard to do. One of the most interesting things about this is when you actually start talking to people that have delirium. The next time you have a patient that's delirious, ask them, ask their family, do you wear glasses? Do you wear hearing aids? And you'll be surprised the number of people that come in here that are delirious, having visual hallucinations, that don't have their glasses, and no one ever thinks about getting them. And if you follow the research, giving them their glasses might make those hallucinations go away. So we're not going to kind of talk about the particular diagnosis, because what we did is we used patient report. I don't know how reliable they are, but one thing I will comment on is that most of the hearing loss is unilateral, and most of the hearing loss is actually left-sided. So left-sided sensory neural hearing loss. So this was a little bit puzzling when we started, because we were like, why is this more common on the right side? But then we thought about it for a while. So in the United States, we drive on the right side of the road, and the driver's seat is on the left chair. So when you drive to work in the morning, and you're tired, and you're exhausted, and you're blaring music to wake yourself up, you're giving yourself hearing loss. And that happens to a lot of us. And that's actually one of the reasons why I think that hearing loss is on the rise, is just for something as simple as that. We looked at a couple other things. So certain things that historically were used as exclusion criteria didn't hold up in our population. Patients that have deafferentation were not more likely to have delusions, cognitive impairment, psychiatric illness, or substance. For clarification, the red are things that we did not find statistical significance for. The bold are things that we did. So most of the exclusion criteria were not helpful for identifying deafferentation and perceptual release. EEG changes were. We're not going to talk about this too much, but essentially, if you look at an EEG of a patient, that has the affrontation, they get a localized increased activity in the alpha and theta band in the sensory cortex. I think this is due to a loss of GABAergic signaling, but ultimately we don't know why. And we didn't even talk to the neurologists. We didn't even ask them to look for this. We just read through their research, read through what they put on the reports, and we just summarized it. But most of the things that historically have been identified as release features were helpful for diagnosing perceptual release in our population. So individuals that have auditory perceptual release are more likely to report deficits in hearing, meaning they knew they couldn't hear as well. They're more likely to be diagnosed, more likely to have any form of hallucination, more likely to be treatment resistant. They're more likely to have complex auditory hallucinations. That's hearing voices, sentences, meaningful semantic content. They also more likely to have simple hallucinations. This is stuff like little knocking, whispers, incoherent sounds. Footsteps is a pretty common one. They're more likely to have musical hallucinosis. They're also more likely to have tinnitus, which is a very common sign of high frequency hearing loss. But some things did not hold up. They were not more likely to have lateralization. They couldn't say, yeah, I think the voices are coming from the left side of the head. They also were not more likely to have insight. So insight preservation, which we hoped would actually be a useful marker, was not relevant here. Patients have so many different disturbances when they're in an acute psychiatric setting. They can be actively psychotic, they can be actively delirious, they can be actively sick. Insight's just not a reliable marker. But stuff like clarity, stereotypies work. They're exacerbating factors. Release phenomena most often occur at night, most often occur when they're alone. Just think about sundowning. You have the characteristic setting for someone who has perceptual release. And there are a whole host of behavioral interventions that can ameliorate them. And one of the interesting things is that a lot of patients actually recognize that sensory optimization helps their hallucinations. Now, in this context of hearing, it's harder because not too many patients have their hearing aids. The people that do, though, realize it. And I've actually found a lot of patients who actually argue with their family saying, I need the hearing aid. It makes the voices go away. And the family will usually say something online that, no, the voices weren't a problem until they got their hearing aid. There's a lot of different psychosocial battles that I've seen related to this. Basically, the same thing stood up for the visual deaffrontation population as well. So same kind of behavioral intervention response, same with sensory observation, same with the isolation, same with all the deficits. They did have an increased risk for Lilliputian hallucinations being small or broad negation being giant. I will comment on that briefly. So Lilliputian hallucinations seem to be from a maybe a more diffuse problem with the visual field. So something like macular degeneration, myopia, whereas every time I see broad negation hallucinations, it's a huge retinal tear, retinal detachment. So I think there's something there. We need more research to know. But we have to ask ourselves, what is the clinical relevance here? And so it's easy to see this and think it's more important than it is. So yes, patients that had some form of sensory loss were 4 times more likely to have treatment resistance. But what we consider treatment resistant hallucinations here is not what we always think about. So we included patients that had non-psychotic hallucinations. We included people that had simple perceptual disturbances. And part of the reason is because I actually think that leaving untreated non-psychotic hallucinations is a risk factor for future psychosis. And there's an ample amount of evidence historically to support that. But where do we go from here? I mean, this is a very extensive sensory exam. How practical is it for us to be doing that on a day-to-day basis? And so this is really why we wanted to do this study, is to come up with something simple. And so that's what we did. So this was the screening index that we came up with from our research. We shortened the sensory exam to just do the Weber test, because when you do a Weber test, you're detecting any form of asymmetry in auditory function between the left and right side. You can catch most conductive hearing deficits. You'll catch almost everything sensory neural. You don't need to do the bilateral rhyme. It's a lot simpler. Observe for cues. And then we made this modified visual acuity test at the bottom. So we use something called the ETDRS, the early treatment of diabetic retinopathy screen. So rather than using a Snellen chart, the ophthalmologist realized, well, the Snellen chart has a predominant flaw, which is that the letters are not the same number on each line. So there's 1 letter, then there's 2, then there's 3. Well, if you miss 1 at the top, is that the same as missing 1 a couple of layers down? And so it's more reliable to actually have more numbers. And so we just kind of copied that. We adopted it for the size as a 10-foot distance screening assessment. And then we did a sensitivity and specificity analysis. We said the patients we thought had perceptual release, what score did they have on this? What about the patients that don't? Came up with these curves. These are a density curve, a kernel density estimation, and we mapped it. And so you have on the top the suspected perceptual release, the bottom the non-suspected. And we found if you put a cutoff at 5, you optimize sensitivity and specificity at about more than 90%. So where do we go from here? Now, I'm not going to talk extensively about treatment. And one of the reasons why is because ultimately we don't know. We have historical research on Charles Bonnet syndrome, but in psychiatric populations, we can't know for sure that that will generalize. But in the absence of definitive research, there is a benefit to thinking about theory, looking at what we have. And I'm still going to try and give you some recommendations for stuff you can look at. So you want to break down the paradigm in a simple way. You have deafferentation, sensory cortex hyperexcitability, silence network dysfunction. This is the normal progression of the illness. When you have deafferentation, that comes in the form of sensory loss. The sensory cortex hyperexcitability, you have simple phenomenon. You may have complex, but they're infrequent. They retain insight. Once they get to silence dysfunction, you have more variable set of symptoms. They're more likely to be psychotic, delusional, anxiety, confusion, delirium. And so there's 6 different ways to approach this. The gold standard for release features for fixing the release pathway is surgery. The cut is the cure. So if you give someone who has predominant hallucinations due to vision loss, LASIX, you give them cataract excision, the hallucinations may go away. Even in individuals that have bipolar disorder, people that have schizophrenia, they can have a profound improvement in their psychosis just from doing a procedure. And there's a very, very big argument to be made here that us getting increased access to these services for our patients may improve their outcomes and improve their quality of life. But obviously, it's not always possible. And so the next step is to optimize vision, optimize hearing, get them glasses, get them hearing aids. If you do this, you're going to at least help control their symptoms. You're also going to help get them to buy into the fact that this is playing a role. Because when they start wearing their glasses, when you tell them, start, wearing their hearing aid throughout the day, be mindful at night that you might hallucinate, they gain insight. And what research has shown is that actually insight can help, getting patients to have insight, getting them to have acceptance, can actually help control their hallucination. And so you could talk extensively about how to approach this with psychotherapy, approach with behavioral interventions. I think the highlights here is that behavioral activation, get them glasses, get them hearing aids, get them a procedure if they need early on, that's going to make a big difference. Once they get to the point they're having simple disturbances, you can see a lot of benefit from just some simple things. So have them use a noise machine at night. Have them listen to the music whenever they're going to sleep. We talked about clear precautions. Well, this is what that is. In addition, if they're isolated, get them out, get them cooperating, get them interacting with their family. There are different simple behavioral techniques. You can do blinking, you can tell people to hum. Sometimes if they have unilateral vision loss, if you patch the eye, you essentially optimize the gestalt vision. Hallucinations get better. And there's a lot that could be said about using CBT and other therapy to try and treat silence dysfunction, especially in the context of PTSD and anxiety disorders. But what most of us is relevant is what we talked about with is pharmacotherapy, what medicines work. So if you want a simple way to look at this, rather than kind of thinking about where you're at in the pathway, if I'm looking at a patient and I'm trying to decide, am I going to give them a low potency antipsychotic or am I going to try and give them a high potency antipsychotic off the bat? Release is probably the #1 thing that's going to make me try something like Seroquel, something like a non-antipsychotic dose of a different atypical agent. Because a lot of times when you're targeting those receptors, you're targeting serotonin 2A, which is heavily represented in the sensory cortex. You don't need the dopamine to get the perceptual disturbance to go away. You just need to lower the excitability. You can also use mood stabilizers. One of the interesting things that you can do is use cholinesterase inhibitors. So there's a lot of historical research on using donepezil, galantamine, ribostigmine to treat Charles Bonnet syndrome. But we don't give that to our patients. But as we'll talk about in a second, there's an argument to be made that we should be doing that. And then there's also obviously a role for isolated serotonin 2A antagonists. Primabencerin, trazodone, or tazapine, and always clozapine works very well. Kind of talking about that in that line of thought. So maybe the best medicine for release features, if you're thinking about it from a theory, could be RXD. So the xanomeline trospium, what it's doing is it's optimizing cholinergic stimulation while blocking serotonin 2A. It's simply lowering excitability through all the mechanism that it has. And that may actually be the best treatment. So we'll have to see. But I think this is also one of the reasons why clozapine works so well for patients with treatment resistant is because many of them have release features. And I'll actually say multiple patients that I've seen that received chronic maintenance ECT, that have chronic perceptual disturbances that people think are pseudo hallucinations, I actually think are release phenomena. Because release phenomena occur when patients are alone at home, they have insight, they come in, they go away, and someone says, well, they weren't really having that. No, they were. They just were having something that we don't usually think about. But the question becomes, when do you have to use a high potency agent? And so I want to try and pull this back up. Remember, attention plays a big role in the perceptual release pathway. And D2 antagonism can and will impair attention. So if you give someone haloperidol who's having hallucinations predominantly as a function of release, which is very common in the setting of delirium, you may worsen their inattention, you will worsen the sensory mismatch, you may worsen their hallucinations. I have a whole list of patients that had tardive syndromes as a consequence of unrecognized release features. So using D2 antagonism in isolation, I would highly encourage you to reconsider. At the very least, think about it. But that doesn't mean you can't use the atypical agents. Risperidone works very well if individuals have salience dysfunction. If someone has an acute psychosis, you need to block D2 to get them out of that fixation. So there's a role for them, but you have to use it cautiously. And I will still say that many patients have had that are actively psychotic have responded perfectly fine to low potency, non-antipsychotic dose of medications. There's a lot that can be said about other drugs, some things I just want people to think about. So there is a small case series that talk about using serotonin reuptake inhibitors for treating Charles-Bonnet syndrome. But historically, there's ample evidence to suggest that serotonergic stimulation worsens sensory cortical hyperexcitability. In old research on schizophrenia, this was actually well known. They tried to avoid antidepressants, TCAs at the time, specifically for that reason. And from my experience, many times patients, if they're on a traditional antidepressant and a serotonin reuptake inhibitor, simply stopping that medicine improves their hallucinations. There's also an argument made for stimulants, all about that attention pathway, trying to optimize vision, optimize the ability to use the visual pathway to pay attention to what you need to do. But the risk for insomnia and worsening psychosis makes me cautious about saying that's a safe treatment. There may be a role, but you have to really use it cautiously. Also of note, benzos likely will help in the acute context, even for a delirious patient, but chronically it's not a good solution, and so forth. Now, another thing to mention, we're just going to kind of talk about the highlights here, is that this is a key area to look at non-invasive brain stimulation. When you have release features, you know that you're targeting a cortical hyperexcitability. And if you shut that down, you may shut off the whole circuit. And there have been studies that directly looked at Charles-Bonnet syndrome and treated it with transcranial direct current stimulation, and some case studies that are done using TMS. So we could talk about this a lot. At the end of the day, think about it. These aren't ready for prime time because you're not going to be able to bill for it. There's a difficulty with access. But there's probably a lot that could be said about using non-invasive brain stimulation to treat patients that have release features. That's one of the areas of interest that I have, is particularly in trying to use TMS and transcranial direct current stimulation to treat depression with release features. So I do want to mention that very briefly. So one of the simplest, cheapest forms of non-invasive brain stimulation is transcranial direct current stimulation. The device costs phenomenally less than a TMS machine. But the problem with the research on it is that the results have been maybe 60-40 for being positive. When you use a traditional transcranial direct current stimulator, you have to excite and inhibit part of the brain at the same time. Well, we always target left dorsolateral prefrontal cortex for depression. It's the most standard treatment. But where do you inhibit? Well, if someone has release features, you inhibit the sensory cortex. And if you think that salience dysfunction plays into the disruption of the default mode, you may actually augment the treatment response. You may see a robust response in patients that have depression with release features. Finally, if everything else fails, ECT is highly effective for release features. Rather than talk about where it works, I talked about different pathophysiology. So ECT reduces serotonin 2A receptor density expression throughout the cortex. It tones down excitability everywhere. Increases dopamine and norepinephrine, which generally speaking also help with excitability. Increases GABAergic signaling from the frontal lobe, top-down processing. It also increases the functional connectivity between all the intrinsic neural circuits. It can help curve out excessive salience or hypoactive salience, excessive default mode, hypoactive default mode. And remember, there's no indication for treating release features. So as we move into an era of using new forms of convulsive therapy, there may be an avenue to use magnetic seizure therapy a little bit more first line to treat these patients. So in the closing remarks, just a couple things I want to tie up. Think about, I would say, learn to assess sensory function. We are physicians. It will help you build rapport. Your patients will respect you, and it will give you a way to stratify treating patients. When you go to give an antipsychotic, it may work 30% of the time, and every antipsychotic may have a 30% chance of working. But it's not the same 30%. It's not the same populations. You have to have a way to stratify how you treat patients. And release features is the way to do that. In addition, in general, I think we all can benefit from being more thoughtful when we're assessing perceptual disturbances. Don't just ask someone about having hallucinations. Think about, what are the hallucinations? Is this a simple phenomenon? Is this complex? When does it occur? What's your thought on it? Do you recognize the thing that you see? Does it kind of display itself over and over again? When you do that, you normalize the disturbances. You actually will help connect the patients. It will make it easier to treat them, and they'll more readily engage in treatment. I'd also encourage you all to follow your curiosities, be open to possibility. So when I started this project, I was frustrated treating patients with dementia. It was the COVID era. Everyone was isolated. Lots of patients were coming in with release features, and they weren't responding to medicine. And I never would have thought that it would actually be relevant for my day-to-day practice. But I actually think now quite the opposite. You know, every patient that has hallucinations, I'm always thinking about, is there a release angle? Is this something I should be altering my treatment for? And thank the people that helped you along the way. I'm not going to name anyone in particular because, to be honest, almost every member of this department has been helpful in this project. I've worked with many medical students, many residents, and I'm grateful for all the help that everyone has given me. So thank you all. These are the citations for anyone who wants to look anything out. And we'll take questions. Dr. Bilbro, if you'd like to go first.
All right. So thanks, Dr. Bonomo. This was really interesting, and it's obvious you've put a ton of work and effort into it and are really knowledgeable on this topic. So I appreciate you sharing it with us. My question is uh, you mentioned that the work you've done is on individuals with acquired sensory loss. And I was wondering if, as you've kind of done your reading and things on this topic, how about those with some level of congenital sensory loss? How does that change, the way you think about this, if at all?
So thank you, Dr. Bilbro. That's actually an excellent question. So one of the things that's really difficult to understand is, when does a congenital sensory loss become acquired? If a baby is hearing in the womb, I don't think that they're all actually congenital. I actually think that's why many patients with schizophrenia have sensory release features. Because what's interesting is people that have purely congenital, that's to say early embryonic sensory loss, they don't ever develop release features. Nothing. But we actually had a case that Dr. Clow and I treated a few years ago that had congenital early on hearing loss, never able to hear. They got a cochlear implant, and once they started turning off at night, they started hallucinating. So to have release features, you need to have a deafferentation. So you have to have the afferent tone, you have to have the expectation in the sensory cortex, and then you have to lose it. But it does raise a good question, which is that ultimately, when you're assessing someone that has vision loss, you do need to ask about the history. If it's been there since birth, it may not really qualify as deafferentation. So thank you.
Thanks, Dr. Bonomo. This is really interesting and fantastic. I was wondering if you could tell us about your experience using TMS to treat this type of stuff, and just more about that.
Yeah, thank you, Dr. Abel. That's a very good question. Well, I will tell you that I have not had any success in getting individuals in to treat with release features with TMS. This is one of the challenges, is that most of these patients, they have some form of thought disorder. And there are a lot of ways to treat these perceptual disturbances without using neuromodulation. But what I will say is that what seems to be helpful is treating Salience dysfunction as well as trying to treat the issues with the actual sensory cortex. And so really the question that we have to ask, we know we're going to be targeting the sensory cortex. We know we're going to be inhibiting that. But where else do we target? how do we make this practical? So when you're looking at building a TMS program, one of the things that I think is important is that it's financially sustainable. And so we know we can treat default mode dysfunction treat depression by targeting left dorsolateral prefrontal cortex. We know that increases executive control. That seems to help treat many different things. It is my suspicion that you can probably treat the primary psychiatric illness as well as target the release area, and then you can make a billable treatment that also will be helpful. But at the end of the day, we need to try and find a better way to get patients access. I've had many patients with treatment-resistant hallucinations that I think would be good candidates, but getting them from discharge from the hospital to TMS is challenging. ECT is a different matter. We've had many patients that do very well with it. But most people understand if a person has treatment-resistant psychosis, they consider ECT. And the question is, how early should that be in the algorithm? And I think that's to be decided.
Any other questions?
One quick question. Where can we find the brief D assessment that you mentioned?
So I can, Dr. Sleem asked, where can they find the brief D? So I can send you all the draft of the one we have right now. I think it's ready for prime time, but we're going to submit this study to the American Journal of Psychiatry. I want to get their feedback. So this may not be the final iteration. If they think we should make a major change, we will. But I have it ready. I can email it to everyone. What I would encourage you to do is you don't have to get hung up on going through it systematically. If you're using it for research, yes, you have to have a measured 10 distance. You have to make sure you're following, asking all the questions. But just pragmatically think about those things. Ask people about them. Because once you start looking for release features, you'll realize they're easy to pick out. And it will help you realize the importance of considering it in your clinical practice.
Some questions?
All right. Hey, Dr. Stewart, we can hear you. Let me see. Are you unmuted?
Hey, sorry. Okay.
All right, we can hear you.
I was
good.
muted. Sorry. Yeah. No sensory jokes there. I won't make a sensory joke. Okay. So, um, that was an outstanding talk. I really enjoyed it. Thank you for all your hard work on that. And I really appreciate sort of the provocation to think about things differently. It's very stimulating. And also the fact that you're doing research really brings it into sort of like the scientific approach to this problem is, I mean, it was great. So my question to you is so I don't I treat, certainly psychotic patients, but most of my patients are addicted, right? But it seems to me like you might have something for me. I might not be totally left out of this. Like,
Right.
should I be asking my addicted patients about their sensory issues and uh, what can if anything, because you're talking about
Yeah, absolutely.
salience and you're talking about parts of the brain that are involved there are some overlapping parts there. So take it away. Thank you, sir.
Yeah, well, thank you, Dr. Stewart. It's a very good question. One thing I will say is ask me this question again in a couple of years, running the detox unit at Mary and Elizabeth, I'll probably have some more insights, but I do have a lot of theories on this. So what's important to recognize with deafferentation is it's not always about permanent sensory impairment. Sometimes it's about sensory deprivation. Individuals that have used methamphetamine, when do they have their hallucinations? When do they have their psychosis? And it's often once they get to the point they're up in the middle of the night, maybe they're crashing on meth, maybe they're acutely intoxicated, there's nothing around them, and they start to hallucinate. So sensory deprivation itself is a risk factor, and many of the behavioral interventions probably would help them if they are willing to participate, if they're willing to engage in them. In addition to that, obviously substances increase your risk for various forms of sensory impairment. I suspect in people that have been using for several years, they would be very likely to have release features. But there's a whole other matter, which is something that we haven't touched on, which is the concept of perceptual release with somatic pathways, with pain. So when I developed the brief D, I thought about including tactile hallucinations, but I realized there's a particular challenge here. When you damage a peripheral nerve, it will sometimes rewire. It will sometimes end up being stimulated by a autonomic nerve. And in that case, you may have chronic pain, but it's more of an illusion. It's a sensory perception from something that's not supposed to be there. So sometimes when you look at phantom limb, some phantom limb pain is related to perceptual release, but some of it is actually an illusion. It's a mismatch. But when you look at people that use methamphetamine, I had a lecture by one of our neurosurgeons actually that talked about it's common for methamphetamine to cause acute rapid clipping of peripheral nerves. That means they develop a neuropathy very quickly. So when you have patients that come in that have Morgellons syndrome, they have tactile hallucinations, they think there's worms in their arms. I think that's actually from methamphetamine-induced perceptual release. I think most of the times it's related to that. And the question is, how do we treat that? Well, you could try the same medicines. You also should consider what is the role here for pain. So we could talk extensively about this, but I think a lot of chronic pain is actually tied to what I call microneuronal damage. You take a tissue, you damage some of the nerves from an injury, it heals enough to still have sensory function, but you still have some component of deafferentation. And so when you look at something like fibromyalgia that talks about trigger points are usually historical injuries. I think those are actually release features. And I think that a big driver for substance use is actual real pain that's a consequence of perceptual release. Are those patients that you want to try giving a little bit of lithium? Do you want to try giving a little bit of Seroquel? Do you want to try Donepezil? We don't know. The sensory pathways have different distributions of different types of monoamine receptors. But there is probably something there. And I think that this could be relevant for addiction research, but it's something we have to look into a little bit more. Okay. Dr. Neal, if you're there, we'd love to hear from you.
Hey, Nick. Great talk, man. Really, just gonna echo, what Dr. Stewart was saying. This is not just the framework, taking all of the available data and information out there and putting it into something coherent and something with explanatory power, but also the clinical research. That's just stellar work, investigating this problem firsthand. I applaud you for that. My question was actually going to be very similar to Dr. Bilbrow's. I was curious about how your framework might explain some of these observations that early congenital blindness, individuals with it are potentially protected from developing psychosis or schizophrenia. But you've already spoken on that, so I'll just say great job.
Oh, thank you, man. I appreciate it. And that was actually something I struggled with early on in the research, is reconciling the data from patients with schizophrenia that suggested that if they're born with sensory loss, they're less likely to become psychotic. And I think that the model explains it, but we'll have to see. What I will say is I do have a friend that I grew up with who had schizophrenia, and I asked him about this because he listened to a lot of music. He destroyed his hearing very early in his life. And he's able to pick out release features pretty well in his life. He's very high functioning. He is pretty good with his medicine. So I think that it plays a bigger role than we realize in schizophrenia. I also think, and this is a caveat with this research, we historically don't think about patients with schizophrenia as having visual hallucinations. And I think that they actually do very commonly, much more often than we know. And we do not have a good way to establish rapport to get them to talk to us about that. And so I think it's something we have to try and bridge the gap, because I think there's something there. And I think it's relevant to help with treatment-resistant psychosis, is to think about the things they're not telling us. Think about the things that if we treat might help more than what it seems. So thank you. Okay. I think that's all our questions for today. Well, thank you all. I hope you all have a good afternoon.